So as you can hear, our theme this morning is to look at subsets of breast cancer. You've heard about triple-negative breast cancer and the therapies being developed, the very successful therapeutic strategy and advancing in the HER2-positive. And we're going to spend the rest of this session talking about the largest group of breast cancer, which are the ER-positive breast cancer patients, and the fact that we have hormonal therapy or endocrine therapy is better termed to treat this group of patients. And arguably endocrine therapy has made the greatest impact in breast cancer. So I'm delighted to have Dr. Beverly Moy, who's a breast cancer specialist at Massachusetts General Hospital in Boston, to address these issues.
So good morning, everybody. I'm Bev Moy. I am going to take the speaker's prerogative because I actually have the next two sessions with you, and I'm going to flip-flop them because I think it actually makes more sense to talk about adjuvant endocrine therapy first and then talk about, sorry. I could just minimize it, and so I could do this. Is it the other one right here? Perfect. Oh, so she had actually, great. Okay, thank you. Right here? Or?
Still on Vista.
Oh, from beginning. Oh, beautiful. Okay. So I'm going to talk about the appropriate use of AI therapy first, and then I'm going to talk about the more nuanced discussion on ideal duration. I think it just makes more sense. And just so you're aware, this first talk will be a bit longer, and the second one will be a bit shorter. So I think that just works better that way. Okay. So I have nothing to disclose. Dr. Schwartzberg actually stole my thunder a bit because I was going to stress how endocrine therapy is probably the most important systemic therapy that we give in breast cancer. And that's because in premenopausal women, approximately 60% of breast cancers are estrogen receptor or hormone receptor positive. And in postmenopausal women, approximately 3/4 of all breast cancers are hormone receptor positive. And in the United States alone, about 400,000 women are on endocrine therapy. And when you think about the use of endocrine therapy worldwide, this is an extremely widespread and effective treatment. So it's a treatment that we have to remember is very important, and we should be using it optimally. There are several unanswered or controversial questions as far as endocrine therapy is concerned in postmenopausal women. And these questions include, when we give adjuvant therapy in a newly diagnosed woman, should we be using aromatase inhibitors up front? Should we instead be using both a selective estrogen receptor modulator, such as tamoxifen, sequenced with an aromatase inhibitor, or vice versa? If so, what is the best sequence? Should we be treating patients for 5 years, 10 years, or longer? And my second talk will be discussing that controversy in greater detail, because I think that's probably one of the most important questions we have in endocrine therapy today. And are there factors that may predict which patients would benefit more from having an upfront aromatase inhibitor rather than a SERM followed by an AI? And that means, are there tumor factors, such as receptors or aggressiveness, or are there host factors, just such as pharmacogenomics, that make a difference? And we'll discuss that in a bit. So this is a summary slide of the major aromatase inhibitor trials in the adjuvant setting in postmenopausal women, and giving you the idea of what their benefits are. And as you can see here, the first two trials are the head-to-head trials, ATAC and Big 198. And what these trials did, as many of you know, is took newly diagnosed postmenopausal women with hormone receptor positive breast cancer and randomized them essentially to upfront AI versus upfront tamoxifen. In ATAC, it was actually upfront anastrozole for 5 years versus tamoxifen for 5 years versus the combination of anastrozole and tamoxifen. And the 4-year disease-free survival was superior in the anastrozole arm with an absolute improvement of 2.4%. with a hazard ratio of 0.83. Similarly, in Big 198, which was another upfront trial, this was a 4-armed randomized trial, but essentially I show you the hazard ratio for the letrozole upfront for 5 years versus tamoxifen upfront for 5 years. And similarly showed an improvement in disease-free survival with the upfront letrozole over tamoxifen of 2.7% absolute benefit of 4-year disease-free survival with a hazard ratio of 0.81. The early switch trials included the IES trial and the ARNO-ABCSG trial. And what this trial did was took patients who had been on tamoxifen for 2 to 3 years, randomized them to complete tamoxifen for 5 years, which was the standard of care back then, versus switching to exemestane, the aromatase inhibitor, to complete the 5 years of therapy. And the patients who switched to exemestane had an improvement in 4-year disease-free survival by 4.7%, statistically significant. Similarly, in the ARNO-ABCSG trial, patients who switched to anastrozole at 2 to 3 years versus completing 5 years of tamoxifen also had an improvement in disease-free survival, similar. And then finally, the last important trial was the late switch trial headed by my colleague Paul Goss at Mass General. And May 17 took patients who completed 5 years of tamoxifen, which was the standard of care back then, and randomized them to 5 years of placebo versus 5 years switching to letrozole, the aromatase inhibitor. The trial had to be stopped early because there was a significant and meaningful improvement in disease-free survival in patients randomized to letrozole over placebo, with an improvement of 4-year disease-free survival by nearly 5%, with a hazard ratio of 0.58. So what these trials tell us in total is that consistently in postmenopausal women in the adjuvant setting, AIs are superior to tamoxifen or placebo in the case of MA17 in the treatment of adjuvant treatment in endocrine therapy. And these trials in total have led to the ASCO technology assessment recommending that in postmenopausal women with estrogen receptor positive breast cancer, that an AI should be used at some point in adjuvant treatment, whether initially or sequenced after tamoxifen. So those are the benefits. What about the downsides? And let's talk about the toxicities of AIs a bit. One of the most important toxicities of AIs is that they have potentially detrimental effects in bone density. And here's a summary slide of bony fracture incidence seen across the trials that I just summarized for you. The first 2 slides are actually the ATAC trial with 47-month follow-up and 68-month follow-up. And as you can see here, the patients randomized to anastrozole did have a significantly higher incidence of bony fracture, 11 versus 7.7 in the tamoxifen arm. And at earlier follow-up, we also saw this trend, both statistically significant. In the IES trial, patients randomized to exemestane versus continuing tamoxifen for 5 years had a slightly increased risk of bony fracture incidence, but this was not statistically significant. And you can see the numerical difference, but it's not a huge difference. Similar in the ABCSG ARNO trial, which has very similar design. In the Big 198 trial, there was a significantly increased risk of bony fracture in patients randomized upfront letrozole over tamoxifen that was statistically significant, 5.8 versus 4.1. And finally, in the late switch trial, the MA17 trial, where patients had been on tamoxifen for 5 years already, there was a slight, perhaps increased risk of bony fracture incidence in patients randomized to letrozole over placebo, 5.3 versus 4.6, but this was not statistically significant. I think one of the lessons learned from here is that, yes, we know AIs have potentially a detrimental effect on bone density. But if you'll notice, the biggest differences are seen really in the patients who participated in the upfront trials, the ATAC trial and the Big 198 trial. So it could be that sequencing AI after tamoxifen, since tamoxifen is considered a bone protective drug in postmenopausal women, maybe that effect isn't as great if somebody had received tamoxifen prior, whereas we might see more of an effect with patients who received upfront AI rather than never getting tamoxifen in the first place. In any event, I actually think that this bony fracture incidence has led to an improvement in women's bone health because the onus has really become on the oncologist to really follow bone health more carefully rather than having the PCPs do it. So if anything, I actually think this could be beneficial because we really have to know this stuff well. We basically have proposed an algorithm which does not have much of an evidence base, but it seems like a practical thing that people may decide to follow of patients who are taking AIs, what you can do for bone monitoring. For everybody, we should certainly be doing a history and physical and doing heights at least annually and assessing their risk factors. A major risk factor for developing osteoporosis is obviously personal history of non-traumatic fractures. And family history of osteoporosis is a really big issue, and those are the things that we should take into account. We should be talking about lifestyle modifications to all our patients, and that includes obviously cessation of smoking if our patients are actively smoking, weight-bearing exercises, and taking calcium and vitamin D supplementation. We should be checking bone mineral density. And if, this is basically some rough guidelines, and they certainly don't have to be followed because there's not a huge evidence base, but if the T-score is normal or greater than -1, we recommend rescreening bone density in 2 years. And if it remains normal, no bisphosphonate therapy is indicated. If the score is between -1 and -1.5, which is still considered in the normal range but could start to approach borderline osteopenia, if insurance allows, you could argue to rescreen bone mineral density in 1 year, but if not, do it in 2. And if it remains in this range, no bisphosphonate. If this T-score is between -1.5 and 2, which is kind of in the osteopenic range, checking vitamin D level might be indicated. I come from New England. About a third of our patients are vitamin D deficient because we don't go outside for 6 months of the year, so that might be something that we would want to replenish aggressively. And you can consider bisphosphonate if patients on an AI and has risk factors, such as a family history of osteoporosis, like I was saying. And if the person falls in the osteoporotic range or is close or borderline, checking vitamin D levels is appropriate, and treating with bisphosphonate therapy probably makes sense, whether it's oral, weekly alendronate, or annual zoledronic acid. In addition to monitoring bone mineral density, we have to remember that bone mineral density tests are not perfect. So if a patient is reporting back pain or you're seeing that their height is decreasing, you really have to take that into account in your evaluation. I actually think that arthralgias, though, are, for me in my personal practice, the bigger issue with AIs. I actually was checking my email this morning and I had a patient email me saying, I'm in this terrible pain from this terrible drug that you gave me, what can I do? And in fact, almost 1/2 of patients who start on AIs have new or worsening joint-related complaints. Most of the time it's very tolerable, but you get the complaints where they say they're very stiff in the morning, I feel like I'm 80 is something that I hear a lot. But most of the time it is tolerable but can be severe. In fact, these arthralgias are usually the major cause of people coming off clinical trial on AIs because they can be so debilitating. I'll say as an aside, and I won't go into this because of time, at this last San Antonio, Jim Ingle presented a really interesting genome-wide analysis where they looked at MA27, a very large adjuvant AI trial, which I'll go into in a minute, and they did genome-wide analysis to see what might predict which patients get bad or severe arthralgias. And they did identify 4 SNPs on chromosome 14 that appeared to be associated with patients getting severe arthralgias. But this is a major thing that I think that we all have had to deal with in our practice because I see a lot of nodding heads out there. So here's another question. What about the optimal sequence of AI? We know that AIs are superior through these multiple clinical trials, but how should we give them? And I think that our data basically is informed mostly by 2 main clinical trials, Big 198 and TEAM. The Big 198 trial was a big trial with 4 arms, randomized, upfront tamoxifen for 5 years, upfront letrozole for 5 years, tamoxifen for 2 years followed by letrozole to complete 5 years of therapy, versus letrozole for 2 years followed by tamoxifen to complete 5 years of therapy. And the TEAM trial, a separate trial, took patients and randomized them to upfront exemestane, which is an aromatase inhibitor, for 5 years, versus 2.5 years of tamoxifen followed by 2.5 years of exemestane. So what do we know? Neither study showed a clinically or statistically significant difference in disease-free survival between patients who received upfront AI alone versus a SERM AI sequence. So that's an important point. There really was no difference between the arms. In Big 198, we saw that each AI-based therapy, so the 3 arms with AI, were all superior to tamoxifen alone. So that really just enforces the point that AIs should be used at some point in adjuvant treatment for our patients.